wanted to know about the school safety and going forward and how we are going to ensure that and what more we could do to ensure that. The third topic is the public health mandates and safety guidance relative to vaccinated versus unvaccinated patrons and employees of businesses. And the details, I'm continuing to call on public health for data on COVID-19 infections of vaccinated persons, unvaccinated persons, where these clusters are occurring. I believe that if we can get all the details out to the public, that they are going to be able to help us in this regard by showing the community what types of transmission is occurring, that they know, so that they can know exactly where these are occurring, how they are occurring, what they can do, and what they should avoid very specifically. Also, I want to talk about whether we have done all we can in regards to contact tracing. It seems that their capacity for it, and I know this just from persons who have experience, are relaying to me that they're not being contacted immediately with the results in some instances. So those positive cases are not being told that immediately. And also, of course, we heard some of this on the radio this morning that we're changing strategies, but I wanted to know about the strategy of the contact tracing, because we had talked about this in prior public hearings, oversight hearings particularly, as to how we were going to increase our capacities to prepare for surges in all of these areas. And so I wanted to follow up today if we had prepared, if we are prepared, or what happened, what was the impediment as to why we were not fully up to speed in all of these areas, these other options for us as a government. All right, so I think we're going to begin now with the first topic. Sure. Welcome to Xenia. Thank you. Xenia Pacina. And so the director had introduced you earlier, and thank you for joining us. All right, so first I wanted to know what are the Department of Public Health and Social Services, what is your ability to treat COVID-19 positive patients at high risk of hospitalization with monoclonal antibody treatment and other at public health or other facilities upon testing? So we know that this treatment is supposed to be done at GMH and GRMC, but I wanted to know, have you developed the capacity? Was it part of your plans to develop a capacity for extending this treatment through public health? Sure. In other ways? And if you could expand on that right now, please.
Madam Speaker, I will respond to that. Of course, my colleagues here, I ask you to please chime in should you have additional information or details to share with the Speaker and members of the legislature and our listening public. So with the monoclonal antibody, GMH is actually already administering that, but they administer that to their current patients. And so they're not standing up a very specific effort just for that. It's already been part of their process for treatment. I believe Dr. Jolene again yesterday evening during the Physicians Advisory Group, Physicians Advisory Group shared that they treated anywhere between 5 and 7 yesterday. I believe I understood that was 7 that they treated yesterday under the MAB.
Sorry, Director.
Sure, no problem.
I'm not sure if it's just me, but I'm having a hard time hearing you. It's either you're talking really fast, or if you could just slow down just a little bit.
All
yeah,
right.
Thank
you.
you.
Madam Speaker,
it's probably
members,
the echo in here as well.
Okay. Madam Speaker, members of the 36th Guam Legislature, and to the listening public, and my team at Public Health and Social Services, I'll respond to the MAB, the monoclonal antibody treatment, and also invite them to chime in should additional information or details be available through them. So I just want to share first and foremost that GMHA has already the capacity for the treatment, and they are treating their patients whom they identify. And so as of yesterday, during our Physicians Advisory Group meeting, Dr. Jolene shared, I believe it was 5 or 7, or I believe it was 7 that they treated. We are also building capacity today through the collaboration of the GARD, Guam Regional Medical Center, and Public Health. We are all working together to stand up today, and it starts at 1 o'clock today for the MAB treatment over at GRMC. Their hours of operation are weekdays from 1 to 5. And so what's happening, as you mentioned, Madam Speaker, is that from testing, those that are then referred over for the monoclonal antibody treatment at GRMC. In addition to those two efforts, we're working with our staff, who is also reaching out to private clinics who may be interested in also operating and managing a treatment site for MAB. In addition, we have already reached out to HHS, Health and Human Services, and they are gearing up to send us a team of 20 members. They call it an administration team, and their focus would be to provide monoclonal antibody treatment, but through subcutaneous or sub-Q. And that would be 2 shots on the abdomen, 1 on the inner thigh and 1 on the upper arm. And that will take 10 minutes and then an hour of observation. The IV infusion is an hour and the observation is an hour. So we're looking at having various options for the people of Guam, but also to have not just GMHA, GRMC, hopefully some private clinics will join the effort. We are also looking at having a public health site for this treatment as an option. And so that's where we're at today with the monoclonal antibody efforts. We are moving forward on this, and we are doing a real focused effort to stand this up so that we can help both hospitals decompress so that we can prevent hospitalization, which this treatment is intended for up to 75 to 80%. And that's what we're doing at this time, Madam Speaker.
All right, thank you. I appreciate that update on your efforts, and we did hear, of course, Chima on the radio this morning talking about also recruiting from UOG GCC in addition
Yes.
to the HHS nurses or persons. So are the treatments, do they have to be administered by, who can administer these? Can they be nurses alone or doctors or EMTs, or what type of capacity do we need for that?
Madam Speaker, for the infusion, it would have to be nurses. But for the sub-Q, will be EMTs or any trained medical personnel.
All right. And so you're partnering now with you said the
HHS.
Health
HSS
and Human
and
Services.
current staff of public health, GRMC, GMH, and also the Guard?
Yes, the Guard. The Guard has
All
been
right.
very critical to our operations, as you already
Okay.
know, ma'am.
Yes.
Madam Speaker, not just with this effort, but also with vaccine and testing, vaccine clinics and testing.
All right. And so you're going to try to set up one location outside of the hospitals to offer this. What about the community centers, north and south? Those are not available for this type of treatment?
Yeah, we were thinking somewhere that would be separate and apart. These was another location that would be separate and apart from our health centers. Our health centers, especially up north, is really tight on space. And if we were to try to set this up there, it would be quite a challenge for us.
All right. And how soon can we expect these? I'm curious, why we are waiting.
Sure.
I actually took a phone call in here from HHS. So we've been meeting with them regularly, and this morning they've actually activated one HHS liaison on Guam. So he started this morning, and he's already met with myself and the director. And we scheduled a Zoom meeting tomorrow morning to discuss further how we can set up quickly. So we discussed the process improvements in our own public health structure, looked at our referral system. We've also identified a few sites that we could use. But the HHS team that is coming is actually a team of 20, but it's 4 teams. These 4 teams can actually set up 4 different sites. So we have a team that can set up 4 different sites on the island coming in from HHS. So we're working on identifying hard structures where they can have the treatment.
All right. Is this something then that was reliant on HSS? It wasn't something we could have just done on our own? We had to wait for them? Why is that?
No, we're actually, like the director stated, we are actually supporting the clinics and the hospitals right now to start the treatment. So this morning, we've actually started the first set of treatments in collaboration with the GONG and GRMC. But that is, the HHS is supposed to come in to supplement what we're doing, and also we've reached out to the clinics who are interested, because the way it works, the clinics can actually order the medication on their own, so they don't even need public health to order it. They can order, and they can actually administer the treatment. And what we're seeing right now is that there's an increased demand for testing in the clinics, and this is also an opportunity for them to have those people who test in their clinics and offer them that same treatment. So they can order the medications on their own.
All right. Can you expand on who are the patients that will be eligible for this type of treatment? I know they're described in the literature as high risk, and then they describe the risk, what makes you a high risk, but I just wanted to, if you could just announce that for the public, what makes a person eligible for this type of treatment after they test positive?
Okay. So there's a two-pronged approach to the treatment. First of all is trying to keep the unvaccinated out of the hospital, because they are the ones who get sicker with the virus. Number two is also identifying people who might be vaccinated with underlying conditions who might also be hospitalized. They're also offering that treatment to them. And then the third one is using the medication as a post-exposure prophylaxis for close contacts to individuals who are positive. So the way it is designed is if an unvaccinated person with underlying condition tests positive, the treatment is offered immediately so that they'll keep them out of the hospital. Second category would also target those who are vaccinated who get exposed. But the third part of it, which is using it as a post-exposure prophylaxis, is what we're going to look at down the line.
Madam Speaker,
okay.
I can also add with that, in addition to what the Chief Public Health Officer is sharing. For example, these are some high-risk factors, and they're not limited to this. Age, someone who's 65 years of age or older, obesity, pregnancy, chronic kidney disease, and these are some examples, but also in the literature that we are using for this monoclonal antibody treatment, it also has reference for, there's anything unique to our race or ethnicity. So those are also factors that could be considered in terms of who would be suitable for this MAV.
All right, so do they require a referral by a doctor, or are the people at the testing sites going to be able to refer them to these treatment sites?
So we're actually working out a triage system. So we changed our testing protocols this morning to accommodate that, because one of the criteria is unvaccinated high risk. So when we identify people who are unvaccinated and high risk, the GONG actually has a doctor on site right now. They get tested with the Binax to check if they are positive on site. If they are positive on site, they are triaged on site and referred for treatment. But in the event that they are not positive on site, because they fit the criteria, we run another confirmatory test on that same specimen. If they are positive, the individuals at the lab will contact the doctor, and then the doctor would continue with the patient. So that way, we're using a two-pronged approach to identify them on site and also follow up if they need a confirmatory test.
If they're confirmed later, not immediately, not on site, which doctor is contacted?
The one who triaged them on site.
All right. And that doctor is going to be able to get a hold of these positive cases and call them up?
Yes.
That's what the doctor is going to do?
Yes, and we have the doctor we're working with at this time, and we're looking to build capacity by having a public health physician also added to this effort, is Dr. Lois Cruz. He's working with us. This is our very first day at this, so we're going to, I'm sure, have a follow-up meeting in terms of how the first day went, how we could improve on the processes. If the processes work very well, then we just want to continue to reinforce that.
All right. We've seen that when we need the nurses and the doctors to be making the phone calls, it really takes a lot of time, and takes them away from what they're doing there on site. So All right,
we
but that's how it is as
Yes,
of
ma'am.
today? Okay, and fees? Are there fees for this treatment?
For public health, there's no fee for the testing, but for the treatment, there's a CMS treatment payment to the doctors, not from public health. It's actually treatment is covered by CMS.
I don't understand.
So the patients are not paying for it.
Okay.
Yes, it is
Covered by CMS?
CMS.
Oh, okay, great. All right. And so even patients who have private insurance, this is covered by CMS? Or are you saying that's for CMS-covered patients?
There's a CMS fee schedule for the treatment.
Oh, okay, so that means Medicaid is covered, but, and those on Medicare, but those on private insurance, we don't know yet? Or whether it would be covered? All right, if you could just clarify that and maybe
Okay.
get that out to the media.
All right.
I want them to know whether they're entitled, if they need to follow up with their own private doctors to get referrals. So it sounds like they're going to need some kind of doctor's referral to get to these treatment centers. If they're positive, if they're unvaccinated, positive, or if they're high risk, positive.
Sorry about that. In working with sorry, sorry about that. In working with the Guard and our other team members of public health and everyone really involved, what you're saying, Madam Speaker, is exactly the direction we're going into, is to message this out so those that are interested, those that are positives, not only will they be aware of the treatment option, but also the cost that's associated and who will pay for that. So that's definitely part of our plan, is to message that out. And our comms team is already much aware of that. They're probably working on it right now as we're here discussing on the oversight, ma'am.
All right. It's, I'm sure that when you get it running smoothly, it's going to be fantastic, like all of your programs are. But this period of this, getting it set up is very almost antagonizing I think, for me, for the public. We want to know what's taking so long. Why not, right? Why wasn't this ready, and what's preventing it? So, yeah, that's why I'm asking about the local capacity versus, are we going to be utilizing EMTs? Can we bring in, those who are trained EMTs at the fire department and others to help in this, if it's needed?
Yeah, Zenya, I think you can share that you're also looking at some other additional stuff. If you could share with the speaker, please. Thank you, Zenya.
Good afternoon. Can you hear me? Good afternoon, Madam Speaker and Senator Brown. I apologize for being late, but I had to go decontaminate after TGen, right, at the testing. But I wanted to just share that today was the first time that we tried a new system because we introduced the monoclonal antibody treatment. And so the process went, it was a little hairy in the beginning, but it's pretty smooth. But we were able to identify, at 1 p.m., we were able to identify at least 26 high-risk individuals that qualified for this treatment. So Dr. Lewis was on site, and he was able to meet with them immediately. Because when we do the Binax testing, they're there on site, they wait for the test, 15-minute, it's a rapid test. They get the results, and he's out there speaking to them and getting the consent for treatment. And then he refers them straight to GRMC or other treatment sites. So it was pretty exciting to see that we did that. Out of the 26 that were identified as high risk as of 1 o'clock, they all opted to take the treatment. So it was pretty exciting.
All right, and that's for TGen, but we are trying to expand testing sites, right? So you're going to need to do that at the other sites
Yes.
if you expand, and that's part of the plan?
Yes, that is part of the plan, not only our testing sites, but also to coordinate and collaborate with the private providers
Yes.
that also conduct testing, so they too have become aware that they're not providing the treatment, where they can refer their patients to for
All
the
right.
treatment.
And is the subcutaneous treatment available in Guam now or not yet?
Right now, the approach being used is IV. The subcutaneous treatment is the team that's coming, that's all they'll be able to offer, is sub-Q. It's a team of 20, and they're called administration team, and that's the other call that we'll be following up on tomorrow. But we have already submitted the request to HHS,
To get the
the team out here to Guam.
but you need a team to do the subcutaneous? You
Well,
can't do it here without them?
No, it's not that we can. We're wanting to build capacity. We just are getting the GDOE nurses, for
Do you have
example.
the medicine to do it? Can a
sorry?
doctor do it right now if they wanted to?
Oh, the doctor, yeah.
We,
We'd have to, we'd have to ask our doctors at the health center, but we're not set up at the health center right now for this. We'd have to talk with them. We haven't had a chance to speak with our own physicians. So Dr. Luis Cruz has been helping us with this, and he's our lead person right now from the physician side. But we're going to be working with our own physicians to ask them to help us with this.
All right, I guess, yeah, so that's the overriding concern that I have, all of this, is that if we were planning for surges and we were trying to think of, all the possibilities that we had, were we growing our own local capacity to do this or not? And if it takes doctors and nurses, then, did we train them, plan for it? Yeah, so
Thanks so much.
do we have the medicines on Guam to do the subcutaneous?
Tests. GMH does have the medicines on Guam, but they're only at GMH. I understand GRMC has placed their order. I don't know if they received it already, but they have placed their order as well.
For the subcutaneous?
No, for the monoclonal antibody.
For the IV?
Well, the monoclonal antibody
Yeah.
is what's used for either the sub-Q or the IV.
Okay, so you can, same medicine, you
Yes,
determine
ma'am.
which method. Okay,
Yes, Madam Speaker.
all right. Are private clinics allowed to get that medicine from the hospitals, or how are they going to get it?
Well, private clinics, I understand, can order directly as well.
Okay.
And so that's why we're reaching out to them to see if they too would be interested in offering this treatment at their respective clinics.
All right. Okay, and I wanted to just, I know this is not a hearing on DOE, but I just wanted to, in particular, if we could give, some, just some guidance going forward. So we see the increasing infections with children who are unvaccinated, of course, because they weren't eligible to be vaccinated. But, so as of, and that, we know that the existing mandate, when schools let out, that was a 3-foot mandate. August 30th, the JIC tracking of student cases noted that there were 116 school-related positives, 63 in elementary, 27 middle school, 26 in high school. And now we're talking about pediatric patients being hospitalized. So I guess, will this information be reported? How many pediatric patients are hospitalized on ventilators in the ICU? And is this information being given to GDOE to help them to assess their mitigation going forward with the goal of opening schools safely? And because at one point the superintendent was on the radio saying that he did not have the information as to how many children were being hospitalized or things like that. So I just want to make sure we don't have any gap in communication of the data. And this is just another one of those. I think the public should be entitled to all the data, and that they shouldn't have to wait 1 month. They should get it on a day-by-day basis, all the details. And so sometimes, the JICs don't give the same details, and sometimes we hear Chima or someone else on the radio giving some details. Sometimes it's Dr. Ann, but I just still can't understand why all the details can't come out to the public every single day, every detail that we know. And at least to help them continue to assess and plan going forward. Prior to the shutdown of in-person learning, GDOE was complying with the mandates of public health at that time. 3 foot for in-class settings, other mitigation strategies, and yet we're still concerned with them, right? And I had just, I wanted to know, we have no data that I can see from Dodea schools as to whether their mitigation strategies are helping them to avoid infections up there. We know from their advertising it earlier on that they had plastics between every student, the cubicles, and they had other things. The HEPA filters inside their building. So I just want to know, so what are your plans for the schools? I mean, have you already decided any changes that will be implemented in these schools as to these guidances going forward? Have you seen any success, for example, in Dodea versus outside? Do we know that type of information?
But I think both Chima and I would like to share a few points. I don't know if Patrick and Patrick, we did some site visits of the GDOE schools. And so some schools are very much able to put forth the guidelines that we have issued out into practice. Some schools are challenged, especially what I refer to as the transitions. And the transitions periods are the arrival of the school students, the class between periods, lunchtime, and the period in which the team was going to go out to observe also when the kids were being picked up at the end of the school day. We did see some schools, I mean, they really stepped up and they had students eating in the classroom for a certain grade. Another group will come in. They segregated, they distinguished playground and said, okay, first and third graders go on this side of the playground, second and fourth graders go on this other side of the playground. So the schools also had like staggered lunch schedules or 2 lunch schedules. They had some cafeterias that had a student desk. So the schools had varying approaches. What we saw was a real hard effort on the staff of the Department of Education to come and do the best they can to protect the school-age kids. But we still had concerns about that transition. And as you have shared with us, the number of positives that were in the school, and these are kids in the school, but I think what's important also is, as of this morning, and it may have changed, and that's why Mr. Patrick is here, we have not had any confirmed school transmission. The positives in the school, and before I go any further, has that changed?
To my understanding or to my knowledge as of today, that has not been confirmed.
Yeah, sorry.
What about going forward? So I just want to know, what have we learned? Sure. What have we learned about the transmission that we can put in place at the schools to make sure that it's not transmitted at schools when we do open again?
Okay. Well, Chima's also been part of the effort. Like I said earlier here, I probably want to respond to this.
Like we know that the schools have been doing really double work, triple work, trying to keep the students segregated. We do know also that there have still been places where they're not that able to segregate the kids, such as transportation and cafeteria, like those types of things, just because of the number of students.
Right.
So I just want to know, we know all those things, and you know what you've learned in the past. What are we thinking of
moving forward? Okay.
Yes.
Okay, so, Madam Speaker, going forward is still using the same guidance, because the guidance was actually meant to have a safer school system. It was designed to make the schools safer. But the caveat there is that we're also going to look at what is going on in the community as we open the schools. And the new guidance has a layered approach to actually keep the schools safe. But what happens is that if there's an increase in the community cases, it also tends to tell us what next actions to take, which was what we did in the last few weeks. When we started seeing the increase in the local cases, we had to shut the schools down, because what happened was that the community increase was actually going to affect the schools. So going forward, the first thing is to look at the cases in the community. So if the cases are low in the community, we continue with the guidance, because the guidance stipulates vaccination as the #1 approach for teachers and workers in the school, so as to protect the kids who are vaccine ineligible. We looked at the seating arrangements, which is the 3 feet and the 6 feet where is applicable. We also have the cohort system, and the cohort system was actually the next step we were going to get into with the schools before we had these huge numbers. Because what the cohort system does for us is to ensure that we're able to keep the same people together every time, so that if there is any new transmissions within the school, we're able to identify where that transmission is coming. And because it's a cohort system, those cohorts do not mix with other cohorts. So going forward, we're still going to adopt the same system And then looking at the how am I going to put it? Looking at the information that we got, when we did the school, when we went to the schools with the superintendent, what we're going to do is actually put up recommendations in place to take care of those outlying situations where the mitigation plan would not happen, because every school is different, and we are looking at a generalized plan, but having targeted interventions for schools that do not meet some of those mitigation measures. So moving forward is working consistently with DOE to address those situations where they come up in particular schools.
So when you say same guidelines with the cohort system, you mean still looking at 3-foot mandates versus 6-foot mandates, still not requiring barriers between the students? And the cohort system, you mean that's going to be like smaller populations in the schools or in the classrooms?
Yes. So what we're looking at is, in the schools, like in the dinings, we can have a cohort of 3 eating lunch at the same time, not having everybody in at the same time. And what it's going to do is, if there's a transmission going on, it's only going to affect one cohort. But if it actually moves to another cohort, it will still be in a bubble where we don't have to shut down the schools, but address those situations as they arise.
All right. Are there plans for expanded testing in the schools, or was school testing expanded with some of the money that you have received at Public Health?
Yes, of course, you're doing screening testing. Go ahead.
All right, so we have the screening testing as part of the school reopening plan. There's a $5 million grant for the school reopening plan for testing. And we've been working with the schools, on how to expand the funds for screening testing in the schools. And 80% of the funds is supposed to go to the schools, not to public health. We're supposed to work with them to give them the money to do the screening testing and just provide guidance.
What do you mean by work with them? Has it been settled yet, or you're just beginning?
We've been working
to make a plan?
Yes.
Or is there a plan?
There's a plan. We're actually
of how you're going to test at the schools?
Yes, we're actually working with DOE and 6 private schools for the testing screening testing.
So they're going to get that money, or you're going to use it for testing at the schools?
It's just testing. The money is just to test in the schools.
Okay.
If I may, Madam Speaker, to add on to Chima's point, we have been working extensively with DOE as well as some of the Catholic and the private schools. And as a success story, I would like to say is that the Catholic schools have fully implemented their testing program in the sense that when we see these kids testing positive and when they identify their close contacts, they don't have to refer them to the Northern Public Health Clinic or to the Teason Outreach. They simply send all of their kids, all of these close contacts, in a manner that fits with our guidance to a certain Catholic school that operates as its own testing site. So that's kind of one of the ideal end goals for this testing program. It's so that we effectively alleviate some of the burden, I guess. I don't want to say burden, but yes, some of the burden on public health. So we've been working with not just DOE, but a good amount of the Catholic schools. And we are seeing an increase in interest, especially given this recent mandate.
Yes, I heard that. That's very efficient from people that are using that one for the Catholic schools. Do you have that in place for the public schools?
That's something that we're still working with the public schools on.
All right.
Yes.
Okay. Yes, because we're all looking for some hope that the schools are going to open. Parents, they call me all the time. They want to know how long are we looking at, and I want to know from public health, how long are we looking at, right? Is this real, or are your plans in place? Are they being implemented, or are we just making plans right now? That's what I want to know.
Sure.
And I guess I want to know the data, if you have it, from the Dodea schools. Have their different mitigation measures been effective or not versus ours? And I know that our teachers have been working really hard, but if we need to give them anything more, I know that there's been a lot of money, brought to Guam for those purposes particularly, and I just want to know if public health is directing them So I hear the cohort system and that otherwise they're doing well, but no plans to increase, for example, sinks or barriers or things like that at this point, just to change the number of students that are there or in bubbles at one time.
Yes,
That's the number one.
ma'am, the guidance actually allows for barriers too. So what the guidance says is, in any way the school wants to, promote safe distancing in school, we work with them for that. Initially it was a 6 feet distance with barriers. There's a guidance for students to face the same way. So all those guidances remain, is what is applicable to the school at that point. Some schools can actually mix those mitigation measures to achieve and protect their students.
And I know you announced this morning about opening up the vaccination again at UOG.
Yes.
And will there be any testing at UOG as well?
At this time, no, not testing.
Okay, so just vaccination at UOG?
Yes, it is a vaccination clinic starting tomorrow at the University of Guam. We're resuming that operation.
All right, and then the public health centers?
Yes, the
For
public
sure
health
they
centers.
have testing. Do they also have vaccinations?
The public health centers are doing the vaccinations north and south, and we're still maintaining the Thursday and Saturday Micronesia Mall vaccine clinics, and we're committed there through the end of September
For vaccination?
for vaccination.
So what
yes.
about testing?
Testing right now, we're doing, are we doing it up north?
So you're doing
Just,
T-Zen?
go ahead.
For testing, we're actually testing at the Northern Community Health Center for the close contacts and people who are traveling for medicals.
Right.
Then at the T-Zen, we're testing every day since the 9th of August. But there is also an increase in demand for testing. So we're having clinics ask for more testing platforms. We're actually training, we just trained the Catholic school to have their to have 14 teachers to be able to test in the school. We've trained
Teachers to test in a private school, you said?
in Catholic school.
Catholic schools?
Yes.
Teachers will be doing testing?
Yeah, the teachers and because the testing is the Binax, is
Yes.
the 15
Yes.
minutes test. We've tested private organizations who have indicated interest, to teach their staff how to test. So what is going on is that a lot of community organizations are actually coming to public health to get that training and ask for support to be able to train their own members. So we're seeing public health, on one side testing, we're getting the support of the clinics, but at the same time, like the GIAA will be trained soon to be able to do that. Custom does it on its own. The judiciary is doing the same. The police, the DOC, the fire department, all these organizations have their own testing platforms. They test their people, and then when they're positive, they refer them to public health.
Okay.
Yes, ma'am.
So that continues, that people can still apply for that type of a program and be trained by public health?
Yes,
You will
and
decide. All right.
yes, ma'am.
Okay, great. The next topic was this, the guidance relative to vaccinated versus unvaccinated patrons and employees of businesses. So when we first heard, some of the changes, we sent a letter on August 5th to Public Health asking for more data and information regarding, at that time, 101 positive cases, because we had seen a slight increase in cases from July 23rd to August 5th. So at that time, in August 5th, I asked for a breakdown of the positive cases that were vaccinated versus unvaccinated. That was not reported. And I think this continues to not be reported up to today. But unfortunately, to that request, I received a report today from the department 1 month later, and it says that on the 172 positive cases from July 23rd to August 6th, close to 2,000, we've had 2,000 more positive cases since then. But in that report, 42% of the 172 positives were among the fully vaccinated individuals. So we knew since August 5th, or Public Health knew since August 5th, that 42% of the individuals testing positive were already vaccinated. 55% unvaccinated. There was also information in the report regarding contact tracing, and it noted that there were 9 case investigators, 3 contact tracers during that time period. And the maximum number of days between investigation to contact tracing was 2 days. And so that's helpful information, but yeah, I think this information is much more valuable. It's real time, right? This is a month later, we're looking back now, but I am asking again. I have asked, I think, at every single public hearing to get this type of data from public health on a real-time basis. So,
Madam Speaker?
Yeah.
Yeah, you know, we have Dr. Ann Pavitsky this afternoon, and we, this is coincidental because she and I have been talking with our team, and so she did a presentation this morning, and the idea is that she would be doing these periodic presentations, and we're even looking at the possibility of a pre-recorded presentation that we would air out, and she would be providing, I'm not sure if it's going to be weekly, I'm hoping weekly, but, you know, speaking with her, she's like, Art, you're not going to see, you know, Director, you're not going to see these significant changes in numbers like every day, every week, but she does have a presentation, and I would ask if you would consider she could share that with the community this afternoon.
All right, well, can you tell us first, what is your decision on whether that information will be released regularly then?
Well, we would like to, Dr. Ann and I are negotiating the frequency, but as she gets it out, we're looking at maybe, Dr. Ann, are we looking at every other week? Can you pull it up? Yeah. So we're going to shoot for once a week. You know, this is data that her and her team pulls together, and
all right.
So what is that?
My interest in it is, I think as policymakers, we're interested in what data is being provided, of course, to the physicians who are advising the governor, what data is public health directly providing to the governor when the governor makes her executive orders and these mandates, and how, you know, how they tie together.
Sure.
And so I'm sure we were all in the same room, we would have all these explanations, but we're not. And so you know that this has been going on for a year now, and we need, I think, if you want to bring the public along, you bring them along every single day, you give them the data every day that you are presenting to other people. This is public data. You give them what the physicians are going to know, and you give them what any other sector of the government is going to know, so that the public as well can hear it and do what they want with it. You know, if you think it's not relevant to them, I don't see why not. If you're doing it on a daily basis, then share it on a daily basis.
Yeah.
If you're only doing it.
Dr. As our territorial epi, we are working towards having a weekly territorial epi report out that she would take the data, and she has graphs and charts that she would walk the community through. And, you know, I was sharing with her that, hey, we could just, you know, instead of doing like a Facebook press con, we could pre-record it, and you could use the slides, PowerPoint, so that she can walk the community through it. And also because of the media wants to take data. It's going to be data that is from the territorial epi, and it's accurate. If people want to replay it and call us up and say, hey, your data is saying this, what are you doing?
I'm all for that, Art. My question is, Director, we've asked for this before, and you did promise before to do it on a weekly basis, and we were getting it on Fridays, I believe, and it was excellent information, and then it kind of faded away, and so that's the issue. I'm sure the presentation is going to be full of great data, but I want to know what is the impediment to doing that regularly. Why did it stop? Why does it stop?
It never stopped. The daily data is produced every day, and it's also released on the JIC. Then we update the SITREP weekly. These other reports have been special reports as needed, like the report today, which is specific to a certain time period, that is all of 2021, and then the last 2 months as we're looking at the surge. So if you'd like to see it, it's got some really compelling data. We have enough to do with the daily reporting that, you know, it's only under these kinds of circumstances when we have the surge that we are running these special analyses. And we're going to be doing more.
All right, great.
Would you like to see it?
I will, and yes, definitely. And so we did, because we asked your office, start to receive in email some of these reports, but I guess I just want to know why we can't show these to the public on or why public health can't show
we'll
it
start getting
I understand, they're not always run perhaps, but
It's
for example, the JICs, I heard this asked to you on the radio. This was one of our #1 questions. When they start reporting, why are they not reporting vaccinated versus unvaccinated on the positives, right? they are reporting it on the hospitalizations, but not on the other. And just that type of consistent information. So sometimes you say it on the radio and you have it available to you, but it's not on those
It's not out there,
checks.
okay.
Yeah.
So ma'am, to answer to that is, the daily cases, when we get those cases, the information you get from is the one the individual puts on the form. But for the data, for the surveillance team, they have to cross-check with the case investigators to dig up more information. Some people do not have their vaccine information at the point of testing. So normally we go to the WebIZ to dig up those numbers. So if we have 10 cases this morning and I report the vaccine numbers, it could change tomorrow because maybe someone who didn't put their vaccine numbers on paper would change. But with what Dr. Ann is describing, on Fridays, we're able to clean up the data and have the right information so that when we present that information, it is accurate but not based on what we have at that point. So we worked on the data that she's going to present now. And another thing is, if you're looking at the daily data, it really doesn't show you much. But what she's going to present is going to compare what is going on now with what was happening before.
All right, yes, that's why I'm asking if that type of data can be released more regularly, because it's exactly like, for example, 300 cases in the 6 weekly situation reports, 300 cases from what reports say are workplace contacts. But that's all we know. We're not able to get from those reports whether those are restaurants versus bars versus government offices versus private offices or some other type of activity, sports. And then we get GHRA and other people coming out and saying they know that those were from bars. So they're getting access to this information, but not all of the public's getting access to the information. So there's been representations out there that, a lot of the spread is happening in certain places and not others, but that's not what these JIC reports are showing to everyone who's trying to look at the data.
Madam Speaker, unless someone else has a different narrative, I just want to say for the record that I don't send information to GRHA. What information they do say they have, it may be through other sources or perhaps just them knowing their industry, that they would share that, hey, there's a positive at this gathering or at this, but unless somebody else does, they may, but for me, I don't send that out. I don't think Dr. Hansen.
But would you say it's fair that there is more information available that you are discussing in other capacities that is not being provided to the public on a weekly basis?
Well, I can share with you like what we do, and it's really a lot of it. Like even the report I presented has information about what the JIC already presents, but I do present that, and I talk about how many people have been fully inoculated, the percentage of those 12 and older who are eligible, 18 and older eligible, herd immunity or herd protection, and so I do those numbers, and that's something that I can definitely share with the general community. I can include that with Dr. Ann's presentation, but it's really just where we are with vaccines and our inventory of vaccines and information that helps us plan out, not just myself, but our partners.
Okay. For example, so we're going to hear Dr. Ann's report today, but executive orders have already been in place, right? Based on supposedly this data. And so that's the disconnect. Do you understand?
Yeah, we get the data out.
If the public is brought along with the data on a weekly basis at the very minimum, then they can understand changes in policy
steps.
based on that, right? And here, a month later, we're going to say, okay, that's great to know, but it didn't help us. It didn't help anybody change their behavior back then. It didn't help them to be informed and say, this is the type of activity that we're seeing is creating spread or whatever. Okay, so Dr. Ann, we will get to that. Let me just finish these questions and so we can allow you that time. So that was going to be my question. I'm going to hope they're going to be answered in Dr. Ann's presentation. Is the clusters, right? Whether they come from businesses, we're told social gatherings. That's the only category we get. So we want to know. I'm hearing now weddings, different things, and though I just, again, if the public hears this is the type of activity, then they might be better, they might act differently. And we're trying to affect their actions, right, with information. So that's why I am, again, and I've done this, I think, at every oversight hearing, almost begged you to release the information as you get it. We want to know what type of businesses, we want to know if it's customer contact or something else, right? And were they wearing masks? Because that would help us. If you know that, if you're able to investigate those types of things, whatever your investigations show that are informing you as to what you want to shut down or not, I would like to see those types of data. Different establishments, what's the difference between them as far as your data goes? All right, and this is also because GHRA, for example, they had brought up other recommendations, right? Limiting capacity in their restaurants. And so they're trying to do that now. Women's Chamber, Guam Chamber, they're making their own recommendations to their businesses about, closing capacity. And whatever it is that I think should affect policy, or what you think the data they're using to make those types of decisions, I would like that to be available. The justifications. So the data that we have now, I guess after we see this, we're gonna, wonder, does that lead us to want to revise any of the policies that you have in place at this time, right? Especially this dichotomy, I guess, between vaccinated and unvaccinated participants at restaurants and bars. And just because GHRA had brought it up about the bars, or Dr. Wen, I think on the radio, also talked about bars. I mean, they're talking about bars are a problem, but I've never heard that really from public health in any of their reports, right? Their formal reports.
Yes, ma'am.
I think you said it on the radio again, and that, but not formally, right? Not in a written report or something like that. Okay. So in regards to workplaces and testing, we are getting calls from different workplaces that are saying they were not notified by their, physicians are not allowed to notify workplaces, only the patient that they're dealing with, whether they're positive or not. So they're relying on the individuals to report to the businesses or to their contacts, right? And so that's a big part of our system right now, is we're relying on people to tell their close contacts.
Right.
And I think they're hesitant to do this in the workplace sometime because, they're afraid to be responsible for implications to the businesses. I'm not sure the motivation, but businesses are calling us to say, how can they, get this information? They want to know, they want to be able to notify the other employees. Have you juggled that? I mean, or,
No.
is there going to be any changes in policy as to that? Or are you still just going to rely on the individuals to tell people who they might have been in contact with?
Well, that's the one approach. The other approach is through the case investigation contact tracing method. Do you have any other thoughts on that?
So typically in the case investigation, test.
Yeah.
Pardon?
You're on.
Oh, okay. So whenever the case investigator speaks to someone who tested positive, they like to go back. First, they identify when the symptomatic onset date was, or if they're asymptomatic, because that's kind of what dictates their infectious period. So that's what dictates how far back and who we need to contact. So whenever we come across a place where they work, an establishment that they've been to, we will note that down. But especially with the workplace, because people tend to work closely with each other, they tend to let their guard down, unfortunately. We'll encourage them to inform their employer, their HR department, their boss or manager. And then we let them know that we're going to speak to them, but we're never going to inform them who the individual is, right? We're not going to reveal their identity to them. But the fact that, let's say I told the director I tested positive, and the case investigator called the director, it makes it easier because he knows that I tested positive. He knows who I've been with, all while protecting the confidentiality and the privacy of that individual. So from there, we work with the manager, the HR department, to procure a list of close contacts who were exposed to the individual who tested positive. And we bring that list back to the positive index case, and we just work it out to narrow it down essentially to find out who is the most direct, who is the highest risk, who are the ones that we should focus on. For restaurants, for establishments where someone had patronized, it's a little bit more difficult, especially because individuals tend to forget or tend to not disclose what time or what day they went or even where they sat. So if, for example, I say I went to King's yesterday, I might not tell you as the case investigator where exactly I sat, right? You had the section on the left side, the former smoker section. So when we come across these situations, we'll again let the individual know that we're going to inform the establishment, but then we're not going to necessarily narrow it down so that the establishment can hone in or identify who that person is. And that's where these contact tracing sign-in sheets really works for us.
Are you requiring the employers, you're trying to notify employers, and are you requiring them to notify the employees?
We don't require them. At the end of the day, we'll still do it because we're the public health authority, but we just inform them that this is what we're going to do. This is what's going to happen.
Okay, so they're not required.
They're usually majority of the time they are cooperative, and they use, majority of the time they come out and reach out to us, say, what do we do?
All
and
right.
then we'll go ahead and explain it to them.
Thank you. So I realize that, we're running short of time here. I'm going to go to the last point, and that is it's the details again on this data of the vaccinated and the unvaccinated individuals, the clusters. And so the bottom line, I'm going to skip through all this and get, is that currently, as of September 2, 6 p.m., out of the 55 hospitalized, 58% were unvaccinated. And so the number of unvaccinated and vaccinated is really have changed dramatically since the beginning, and now they're so much closer in percentages. And I guess that I just wanted to ask if this, I know you continue on the radio today to talk about we want everyone to get vaccinated, and I understand, the rationale, the decrease severity of the cases, but I guess you're going, do you have hospital data in your data as well? Okay, great. Okay, so I'm going to leave that until we get to your data. It was mostly questions about this surveillance data, what we did know, but what we were not able to find out in those. Okay, great. All right, so let's allow Dr. Ann to give her presentation at this point. And then we'll allow my colleagues to ask some questions as well.
They just have to load it up on the screen.
Yes, they will.
Okay.
So if we could get the PowerPoint. Audio, can you load the PowerPoint from Dr. Ann? There it is. There you go. Sorry, Dr. Ann, I can't hear you.
Now I'm on, okay. The data I'm presenting is a little different. I did it especially so we can take a look at all of 2021 and then take a look at July, August. And that's what you're going to see in the graphs. It's going to switch from all of 21 to July, August to look at what's been going on since we started vaccinating, basically. If you want the daily summary, it's on our dashboard. The dashboard is being improved, but we still have the daily summary up there. And that gives the summary for the beginning of the pandemic to the present time, the last 2 weeks in trends, and a daily summary. You're not going to get details about restaurants and any of that, because by the time we have that information, it's already the event has passed. Please scroll down. This first graph is for all of 2021. As you can see, there's our surge there in August. We looked really good in March and April. We did see cases January, February. We looked really good March, April. May, we started to see an uptick. Remains kind of stable, and then boom, there's a surge in August. Now the orange line is the 7-day rolling average of cases. Next slide, or next page. This is just July and August, where you can clearly see the surge beginning in early August. I'll show you another slide later that shows we did start to see some concerning trends prior to that. Next slide. This is probably the most interesting slide here. This is the hospitalization data. It's kind of hard to see, but this is just hospital cases. If you look at early January 2021 and February up through March, you can see we didn't have a lot of cases in the hospital, but most of them were in the ICU. You can see that. There's a lot of ICU cases. Then it kind of dips in March and April, and then they started to see an uptick in May, and then we see our surge. But what's interesting about the far right on that graph is there's a huge number of cases in the hospital, but the number in the ICU is approximately slightly higher than in January, February. That's showing you likely this herd protection. That there's a lot of people in the hospital, but they're not on the ICUs. They're not having severe illness. They're going to the hospital because they're scared and they're sick. Next slide. Oh, wait, before you go back, sorry. The deaths in 2021, there have only been 27 deaths, and there's 2 now in September. That's not on the graph. That's very low. It's a significant decrease from last year. I think if we hadn't been vaccinated, we'd probably be over 200 deaths. Next slide. This is the same thing just for July and August, and you can see, again, huge numbers hospitalized, not as many as the ICU. And in July and August, we only had 7 deaths. We've had 2 in the last 2 days. All but 1 of the 27 deaths were unvaccinated people. These are preventable deaths, except for possibly the ones in early January, February. The only person who died who was vaxxed had several severe comorbidities and was an elderly woman. So the vaccines are protecting against severe hospital issues, and they're protecting against death. The vaccines are working. Next slide. I'm going to kind of jump. These next 2 slides just show the proportion of cases that are symptomatic or not. That's for the whole year. There's no real discernible pattern. It's a mishmash. Next slide. Same thing with this. There's no really discernible pattern. It's a good mix of symptomatic and asymptomatic. It's not like we're seeing a clear trend in breakthrough cases or anything like that. Next slide. Oh, this is comparing the Department of Defense cases and our civilian cases. And this is what we started to see approximately 8 to 10, was it 8 weeks ago? We started to see an uptick in the military cases before we started seeing a big uptick in the civilian cases. And the military cases have remained steady, and then the civilian population, the surge has just exploded. We just wanted to take a look at that. We might take a look at that further later on by village. Next slide. Again, the blue is the DOD, and you can see, actually, you can see the uptick we saw. I can barely see. It started in July. We started seeing those military numbers increasing before we saw the civilian numbers increasing. And that's what we were watching. We were concerned about that. We were watching it, and then boom, it just all took off. And there's our surge. Next slide. This is by age. You can hardly see it. I'm just showing that the case rate was low among all ages until the surge. Next slide will show you the details. As you can see, the gray line is the group that's driving most of the cases and infections. It's the 18 to 39 group. That group is one of the lowest in terms of vaccination. I guess they think they're immune. The 18 to 30, young, healthy adults, they think they don't need a vaccine. We also saw an uptick, again, as you see the kids, 12 to 17, that's the orange line, that we've seen a recent uptick, as well as those 0 to 11, that's the blue line. And then the 40 to, I can't see it, 40 to 59. The elderly, even though there's been an uptick, it's been low. That's likely also a protective, herd protective factor. 90% of those age 60 to 74 are vaccinated. About 71% of those over 75 are vaccinated. We need those numbers. That's not safe enough. We need to get 90 to 95% of middle-aged and elderly people to be vaccinated. And of course, the kids under 12 are now eligible. The lowest group is the teenagers. They could also be vaccinated. Next slide. This is basically showing our testing and the positivity rate for the testing. And just shows you how much testing we're doing during this surge. That's for the whole year. Next slide. And you have copies of this. It's a PDF, and there's our July, August testing and the positivity rate. Next slide. This is the proportion of breakthrough cases, or these are numbers or proportions, I can't see. Breakthrough case numbers are in blue, and the unvaccinated is in red. So we're seeing a surge. Yes, unvaccinated people are also part of the surge. Next slide will give you July and August. And it almost mirrors each other, right? But the important thing to note about this slide, the last data we had was from the end of August. The unvaccinated rate is 6 times higher than the vaccinated. Even though there's an uptick, we're seeing breakthrough cases. All of these vaccines were designed for the Wuhan strain, not Delta, not Wu, not Lambda. So we are seeing breakthrough cases. We are seeing them at the hospital, but they're not in the ICU. So we're not seeing the severe illness and death that we saw last year. This last 6 months, we've really seen the protective factor of vaccines. And there are some people who are talking, epidemiologist, I forget her name, she's at Columbia University. She doesn't talk about herd immunity anymore. She says we got to talk about herd protection. Keeping people out of the hospital, maybe getting treatment, urgent care, hospital, making sure people don't die. That's what we need to do. And that requires getting the vaccinations up. The vaccines still work. It's a protective factor. That's my presentation. I hope you enjoyed it.
Yes, thank you very much, Dr. Ann, and I will provide this to the senators and to the public as well. I appreciate it. I would just like to conclude by, before I open it up for the senators, that, for example, there was a time we could get information as to restaurant-specific or workplace-specific. We were getting school-specific data, but not these other types of data or information. And for me, that type of data translates into people when we're not able to contact them fast enough to let them know they might have been, exposed. They act on their own, and they are able to use that information to act on their own to know, I might be exposed. I better not go, visit any relatives or get near the baby or get near, they will do that. And that's the reason I want this information available to them faster, the more actionable, so that they can make it actionable. And some of the data Dr. Ann provided, if we had known it at the time, would we have acted differently, right? That's the question. For example, I know KUM had talked about the difference in the numbers between the military and civilian population in the very beginning of the surge, and whether there was any action that could have or did come out of that.
Can I answer that?
Yes, please.
When we started seeing that uptick in the military cases, we have a weekly Department of Defense meeting which Patrick chairs, and it was the day after that meeting, that was on a Wednesday, it was that Thursday that the The brass, military brass, decided to require masks for the military. Yes, so we were on top of that. And then it was after that, a couple weeks after that, they then decided they're going to vaccinate the military starting in September, because we know that's a young population. They think they're immune. They're walking around without masks, et cetera. So yes.
Yes, thank you. An additional information regarding those who are hospitalized. Sometimes we talk about they had comorbidities. Sometimes when they die, we talk about that, but sometimes we're not talking about that anymore when they're hospitalized. Or, for example, what factors diabetes plays in particular, right? And I thought we had learned from the past that that is helpful too, because you find out that you're super high risk versus just high risk, right? And that you're going to act differently. So again, we want actionable information, right? Information that would change behavior. And so I'm not gonna, I know I've asked you this in the past, and just the vaccinated versus unvaccinated, if you could include that on your JIC reports, just to show people, if we're trying to show them that even the vaccinated are at risk of spreading this disease, then let's just show that data, all right, as much as possible. Again, we want to affect behavior. So I'm gonna now allow Senator Brown. Thank you for your patience.
Don't worry, Madam Speaker, I'm just a little tired this afternoon. Doing Google Classroom is draining. I have to tell you, but thank you very much for the presentation. I think it's very eye-opening, the data that you provided. And thank you to all that you do. I mean, this is a lot of work. I mean, I don't know if there's ever a time that you've been with public health, and Art, I know you've been there close to over 30 plus years. The only difference now is we have to use reading glasses to read these days. But, you know, the magnitude of the work that you're all involved in, and getting the awareness out in our community, doing the testing, getting the vaccinations out there, and then obviously collecting all this data so we can put it together and make some sense of it. I think the good news, at least for those that have been vaccinated, at least it's good to hear that we're seeing a reduction in the amount of the degree of the illness and fatalities. I think that's a very, very good information, even though we're seeing more people affected by it. And then also now we see and hear more about our children, children that are testing positive. I just want to get some feedback with regards to that. Is why do you think that's happening now with regards to children? Because early on last year, the information that was provided, it's like, well, children are not as affected by it. And now this round, I don't know if this is a Delta strain or what the case may be, that we're seeing children, younger children affected by it. And then your data also showed that the teenagers, the young adults, you're right, maybe we used to think we were, you know, immune from everything back in the day. But to know that that age group, certainly an age group we need to focus on. But just want to get your feedback, the difference now between last year, particularly with our children.
Okay. And Madam Senator, there's one other information that is good to share, because last year at this time, we had a huge cluster of cases in the barracks. And those barrack cases were what drove our numbers very high. But at this point, we're not having any of those barrack clusters, because most of them are vaccinated and they're actually using the preventive measures that are being prescribed by public health. But as at this point, we're seeing a lot of community spread. And we can only point out that it is the Delta variant, because it is so aggressive. It has actually changed our process. The older variant used to take at least 5 to 7 days for it to be detected by the PCR test. The Delta variant is 3 to 4 days. But the transmissibility is so high that even within the family unit, and this is what we're seeing with our data, is that families are getting so hard hit, because you test an individual from a home and you tell them, please go get tested. When they go out to Tizan to go get tested, you're seeing 6, 7 of them turning positive. And at the beginning, and when we started noticing the cases middle of June or July, I spoke with the team and we agreed to increase our testing capacity. We were testing once a week, and we were testing at least 300 cases on Tuesdays with the support from the hospitals. But when we started noticing those numbers, we met with the director and we agreed, and he approved for us to improve our testing strategy. And what happened was that we started testing from 500 to 800 daily. At some point, we capped at 700 cases a day. And the surveillance team started noticing the increase in number of families. But in the reports, you see an individual family with 6 positives. But these positives are school-age kids. These positives are workers in establishments. But what we're not seeing was a huge number of increase in the number of cases in the establishments. But in the household, it was increasing. And remember, Guam never stopped the mask mandate. So that was why when people go out in public, they are wearing the mask. So it actually helped us in limiting transmission in the public places in some circumstances. But at home, the fire was actually raging. So when we started noticing all this, we now started, when we speak to the family members, Ms. Zina here is actually one of the nurses that reach out to the positive cases. We tell them, please go get your family members tested. I had a meeting with the director, and we agreed that we take resources into the lab. Because what we're doing in the lab now is that normally they get the results, they transmit directly to the nurses. But right now in the lab, if you test a T-zone, you are symptomatic, but you don't test positive on the Binax. The result is taken to the lab and run on the Gene Expert, which gives you the test result in 45 minutes. And the reason being that as we're seeing that uptick in cases, we're using the PCR to actually target the infections, but we're also looking at people who had symptoms so that we can target them. So now you're seeing this increase in numbers because we're testing more, we're reaching out to families quicker than we're reaching out to them. So it is a balance. But what has happened is that the Delta variant has changed the game. It's a new game changer, but what we've been able to do is increase our strategies to try and make sure that we test as much people as we can, isolate them. With this new treatment strategy that we have now, we actually have the vaccines on one side and also this treatment option. So what we're going to see is that in the next few weeks, with all these strategies being in place, we're going to see the cases start dipping. So that's what is going on right now.
I do have a lot of other questions, Madam Chair, and I appreciate the information you've all provided. I think this gives us a lot to absorb, to be aware of, but I do know we have a couple other colleagues on the line, and I know we have a 4 o'clock hearing, so I will suspend any further questions. But again, thank you very much for the work that you do and to continuing to communicate with us and the public. It's a very scary circumstance for all of us, and certainly the more information we have for people to make decisions, those that are unvaccinated or choosing not to get vaccinated, information is still very valuable to get out there to our community. So thank you. I appreciate all your efforts. Thank you, Madam Chair.
Thank you.
Thank you very much, Senator Brown. Senator Taitugui.
Thank you, Madam Speaker, and thank you to Public Health for all your hard work. Really appreciate the information you provided today. And now that you're saying that most of this information can be done on your website, we can find some of this. I hope it's updated regularly. I think that's really important. I do have a question with regards, Mr. Director, with regards to the Regeneron treatment. Was Public Health collaborating with the private clinics on early on if they wanted to participate in administering this immune therapy?
Yes, Tess. Can you hear me? Okay. Yes, Public Health is engaged. We have a person on our staff, Fernando Esteves, and he's helping us, and he's reaching out to the private clinics. He's also been very instrumental in the setting up of this treatment, the concept of both. Right now it's IV infusion, but we're working also for Sub-Q, and so he has been instrumental. And as of this morning, he's sharing with me that he's getting some positive feedback from some potential clinics that may be interested in offering this treatment.
Okay, how soon did you get them involved?
We are just rolling this out. So Fernando just gave me that information this morning for the private clinics.
So you're just doing this now?
With the private
Okay.
clinics, yes. We had a physicians advisory group last night, Senator, And I think
Yeah.
Fernando took the opportunity to reach out to them and perhaps has done even more than that, because that was a report, an update he gave me this morning during a brief, that he said that, he's getting some positive feedback. I don't have numbers or clinics yet. We haven't had a chance to meet, to reconnect with regards to those details. But I'm sure that, he's one that's really working hard and fast on this, so I'm sure he's going to get some real traction on this.
Okay. A lot of the questions were answered, and I know we're up against time here, so I greatly appreciate everyone there. Again, all the hard work that you're doing. I want to take this opportunity right now to wish Chuma a happy birthday as well. I know. Sorry you have to work on your birthday, Chuma.
Thank you so much.
Okay, happy birthday to you.
Thank
Thank you,
you.
Madam Speaker.
Thank you very much, Senator Taitukwi, and to the other senators that were on with us up until the questioning part, Senator Schultz and Senator Blas. Thank you very much. And again, happy birthday, Chima. Thank you for being here. And thank all of you. I know we couldn't get to every topic that we would have liked to. There's always so much information because you're a huge department doing a huge amount of work, and I very much am grateful for you. I want to just do these hearings to make sure that between you, us, and the public, we are all on the same page so that we can help you move these things along faster. And again, you've done a great job with the vaccination, rolling those out. They ended up, running so smoothly, and same with the other programs earlier. And so we're looking forward to success with this, the treatments that we're going to be able to offer those who are positive or those who are very high risk. And so I want to get those to them as soon as possible. Let us know if you need our assistance in changing agency, capacity so that you can, whatever resources you need, if we could help. I'm sure the governor is offering everything. She's also very excited to get this out. So
Yes,
we want to see it made available. If there is any other treatment that you are considering, I'm hoping you're working on the plan already and getting it here as soon as possible, and that we can do it as much as possible ourselves so that we don't have to wait for others to bring it to us. The data, I'm going to just put in one more plug for this data so that we can get it as soon as possible. People can act on it. People can change their behavior based on what you can provide to them. Especially when, I know you're doing your best with contact tracing, but it seems to me that despite all our previous oversight hearings regarding the capacity to trace quick enough if we have a surge, this is a huge surge.
It's a huge surge.
And that our capacity is limited, and so we need to find other ways. And so get the data out, and it will help. I think let us know your plans, as we've always asked you, how you're going to grow your capacity is supposed to be grown permanently, right? Because we knew already going forward, you need a bigger capacity to do contact tracing to prevent surges, not just of this, but other communicable diseases. And you had told us that that was part of the plan, and that was the purpose of trying to hire additional personnel. But yes, so I want to see that those efforts are actually paying off, and that we're not just going to continue to get into this situation over and over. I want to show the community that these efforts and your efforts are very fruitful, and that they're giving us information that we are using to change policy, right? If we're going to change policy on the government side, it has to be informed. All right, and that's really the bottom line. It has to be informed, and if we're guessing or we don't know, I say that straight out. You know what I mean? That maybe we are going to try 3 different things. We're not sure which one's going to work, but say it that way. I'm open to that, as rather than we're going to do this because we are sure it's going to work when the data shows otherwise, right? Or the data doesn't show that at all. Okay. Anyways, I think you get my point, and I want to thank again the senators for being here today, and thank all of you, and wishing you well and to keep safe, and thank you again for all of us to helping us to keep us safe, and I know it's been very difficult, but thank you again also for keeping the media informed. I think the more you do that, I heard you on the radio this morning, Director. I heard you, Chima, almost every day. I used to hear the 2 of you very often. Xenia, of course, I've heard you on the radio too, so thank you. I just think that helps, right? And give them the facts. Just give them the facts. They will deal with it. Don't hide it from them. All right. That will conclude our oversight hearing. It is about 10 till 4, so 3:50 p.m. And si Diyos masi again to the entire Department of Public Health and Social Services. Take care. Be safe.